You're listening to Online Pet Health Podcasts with Dr. Megan Kelly. Continuing education for veterinarian rehabilitation therapists. Learn more at onlinepethealth.com.
Hey vet rehabbers, today I chat with veterinary surgeon Steve Wimberley from Westville Veterinary Hospital in KwaZulu-Natal in South Africa. We discuss cruciate ruptures in small versus large breed dogs, the criteria he uses to decide between going for a surgical versus a conservative approach, and how he uses a technique called prolotherapy and has completely changed his outcomes in these cases. Now, prolotherapy is a procedure where a natural irritant is injected into the soft tissues around an injured joint, and this actually kickstarts the body's healing process. You can find out more about prolotherapy in episode 2 of the podcast, where I interviewed Steve in 2017 about this technique. We also have some free training by Steve in the Online Pet Health Members portal under complementary therapy, and for non-members you can access the 30-minute training in our free area. You just need to go to www.onlinepethealth.com/free and you can sign up to our free area. Over to Steve. Hey, Steve, thank you so much for joining me.
Yeah, hi, Megan. Pleasure. Honored to be with you.
So, Steve, I was actually looking at our archives of our podcast, and you were actually on our episode number 2. I can't believe it, because we're on like over 150 podcasts now. And we were speaking about prolotherapy. And this is something that we're going to touch on later on in the podcast today. But yeah, that was all the way back in 2017.
Yeah, incredible. And you look exactly the same, and I'm not sure about me. Yeah.
we both look as young as we were then.
Yeah.
Steve, why don't you tell the listeners about yourself and how you got into the field of veterinary science?
Yeah, sure. I really was born with this love for dogs. From the moment I could walk, particularly dogs, but all animals. But I would just take my dad by the hand and take him down the road, and we would have to stop at every gate and pat every single dog, regardless of size, fearsomeness, aggressiveness, whatever. It didn't scare me. I just wanted to talk to all the dogs, and that was what I was born with, and I wanted to work with dogs especially, and I've been very blessed to have been able to do that for the last 33 years in private practice. So that was my calling, and I've been, as I say, very blessed to have been able to work in that field. I've really just been at one practice, Westville Vet, since 1988. I've tried to emigrate a few times, but failed dismally. And I'm just happy to have been in the same place and learned so much over the last 33 years. And hopefully I can share some of the knowledge and experience that I've gained.
And what's amazing is that your son is following in your footsteps. Is he exactly the same? Does he have that love for dogs?
Absolutely. He has love for all animals, but definitely a affinity for dogs and cats. Yes, he's in second year veterinary. My vet friends say it's the worst case of bad parenting they've ever come across. But he's wanted to be a vet since he was 10 or 11. He didn't tell me. I was the last to hear in the family. He told my wife and my 2 daughters years before me, because he didn't want me to be negative about it. But I'm actually very proud of him. And he wants to be a surgeon as well. So it's really nice to have someone follow in your footsteps.
Yeah, well, I tell you, the trick that I've used is I just tell my girls about having to put your hand up a cow's bum. Yeah. And that's completely turned them off. So I don't know, did you not try that one?
No, because I've written a book of short stories and of things that have happened to me, amusing things as a vet. And one of them is called, one story is called The Warmest Place to Be. And it was on the Highveld as a student in the bitterly cold winter morning of -4 with the wind blowing, and we were doing our first rectal exams in cows, and we were in our beautiful clean overalls, and it was the first time we were going to get our hands dirty, and put the gloves on and went up, and the only thing I remember is how wonderfully warm it was. It was just magnificent. I didn't want to ever come out of that hole.
Yeah, I must say it's completely turned my kids off. My youngest is she has the same affinity that I had for animals, and is amazingly not scared of any animals. So I've got this 18-year-old Jack Russell, who I have to give subcutaneous fluids to. She's got kidney problems. And my 6-year-old is the only one that is brave enough to hold her when I do it.
Okay.
And, the typical Jack Russell, she's quite snappy, and she's got no fear whatsoever. So yeah, we'll see what happens. So we've still got a few years left.
Yeah.
Steve, today we're going to be chatting about cranial cruciate ligament ruptures and trying to just sort of iron out the differences between our small breeds and our large breeds. Now, you are a surgeon, so that's your main thing that you do. I know you do normal consults, but in the practice that you're working at, surgery is your main thing, right?
Correct, yeah. And knees have been my thing since 1981, first year anatomy, when I opened a knee and looked and I said, this is cool, and this is going to be my interest for the rest of my life, and it actually has been. I just do so many knees. So I've got so much experience to share for those who want to hear. Yeah.
I mean, do you know how many cruciate operations you've done over the time? Have you counted?
It'll be over 1,000.
Yeah.
Yeah.
Steve, what is the main difference between, our approach to these cases? So when we have a small breed versus a large breed that comes in with a cruciate rupture, what is the main approach that you take?
Well, I think the first thing that goes through your mind as the surgeon is the smaller the dog, the better chance you're going to get it healed, whatever you do. They're just less challenging. So the pressure's off a little bit. You feel like you're more confident tackling that than the bigger dogs. There's less room for post-op complications, and generally they can come right despite what you do almost. So if we're talking little dogs under 15 kilos, many will actually self-heal if you give them long enough, 6 months. So people come in and hear the options and go away, and you never hear from them again until the following year when you need to vaccinate, and the dog comes running in fine on 4 legs, and you say, well, did you get it operated somewhere else? And they said, no, we took so long to think about what to do, it actually came right by itself. So little dogs can rehab themselves, and we can certainly encourage healing in many ways other than surgery. But then surgery is also often successful in little dogs. Most surgeons will get over 80% success rate in little dogs with a cruciate repair.
And are there different techniques that you would consider depending on the size of the dog?
Yeah, definitely. So the X-cap repairs, of which there are many described because none of them work perfectly, they in my hands, they all give me about a 65 to 70% success rate across the board, but it'll be higher in little dogs. Just my stats across the board, so from 5 kilograms to 90 kilograms, my X-cap stats on the owner surveys I've done give me 65% full return to function, but that's owner subjective opinion. 25% very, very much better, hardly limp, but if they overdo things, they come up lame for a day or two, and then roughly 10 or 15% fail. But if I had to break it down, which I haven't done yet, just into 15 kilograms and less, then I would say success rate there with the X-cap surgery is going to be 95%. So I haven't felt the need to try different techniques like TPLOs or TTAs in the little breed dogs, unless there's a very, very steep tibial plateau and your X-cap fails. So if you do an X-cap and it fails, you've got a good chance a second X-cap will fail. So then maybe look at doing the TTA or equivalent. But up to now, I haven't had to do that in the little dogs. Yeah.
What is the main reason that you think that you get those failures? What are the main causes?
So the forces on the knee that cause the ligament to go in the first place are still in that knee post-surgery. And so you're going to have the same cranial draw or anterior thrust on your X-cap suture and can cause it to stretch and break. In fact, most X-cap sutures we put in are loose by 8 weeks to 10 weeks. If you had to sedate the dog and palpate how stable that knee is at 8 to 10 weeks post compared to immediately post-op, most of them will have loosened up. And what actually saves that knee and what allows the dog to heal is more the periarticular fibrosis you achieve with surgery and putting an implant in there, which then allows the knee to tighten up and your anterior thrust is reduced or your cranial draw is reduced, and so that when the dog weight bears and the quadriceps contract, there's no feeling of slipping. So the femur is not slipping caudally on the tibia. When the dog weight bears, it feels stable, so they run fine. So the main reason for the breakdown is the dog's same forces are on the knee acting that cause it to go in the first place are now on your new ligament. And if they run too soon and before you've got nice scar tissue formed there, then you will have a failure. So confinement is one of the biggest challenges in doing any kind of cruciate surgery. It's one of the things that frustrates the surgeons the most, because you can do the most beautiful surgery, but once the dog's out of your care, you've got no control over what happens to it. And most of these are very energetic dogs, and the owners, despite their best intentions, and they can even be the best owners, the dogs just don't stay quiet, and they jump and they run, or they get out the gate when they shouldn't, and they overdo it, and they break it down, and then you've got your consult that you dread with the 5-week post-surgery coming in limping worse than before, so, and you go, oh no, and what do I do now, kind of thing. So that's the challenge of all dogs in cruciate surgery.
Do you find that the owners come in and they're hesitant? I mean, from a rehab perspective, we often see clients that the first thing is, how can they avoid surgery? So they're
Absolutely.
always wanting to opt for that conservative approach. And I don't know whether this comes from the human field, because I know, with certain knee pathologies and injuries, you don't need surgery. So I'm not sure where it comes from, but I find from my experience is that first thing is, can we get away with not operating?
100%. That's the most common experience I have with owners when you tell them that they're cruciate. In fact, many come to me now because their vets told them it needs surgery, and they've come to me to find another way. So I get a lot of referrals for a conservative approach. So where does it come from? I think it's changing trends in human medicine, which then filters into veterinary medicine. So, orthopedic surgery really took off in the 50s when the Swiss developed stainless steel implants, non-rustable implants, and surgery was safe in terms of superbugs, and we weren't getting super infections, and we had nice new implants to use, and it was all exciting. And the whole thing was fix everything you can with surgery if you can, because that's going to be your best results. And now in the last sort of 10 years with superbugs in hospitals and people really scared of surgery and the complications and the side effects in people and what we're witnessing in dogs as well. I mean, if you get some of these horrible bugs in the joints, that's it for life. You can hardly ever get those joints right. So there's a swing to try and now fix things without surgery if we can. And it's a growing field, and it's a wonderful thing to be part of, because although I'm a surgeon, at this stage in my career, having lived through many, many surgical disasters and times when I just wish I hadn't operated, if I can find a way now of not operating, I'm fully on board, and I'm going to try that first. So basically, in my hands now, my patient's got to earn his surgery. He's not just going to get his surgery; he's got to earn his surgery. And so I've really enjoyed the conservative approach to cruciates. I found it amazingly successful, way better than I ever thought it would be. And in fact, a client coming to me with a dog with a cruciate injury, it's going to get prolo and conservative first, unless they're very adamant they want surgery straight away, or unless I'm pretty sure there's a meniscal tear in there as well. So otherwise, we're gonna go prolo and rehab, knowing that and this is a thing that unfortunately most vets won't impart on owners, is that I can still get a great result with surgery 8 to 12 weeks down the line. If I've started prolo and rehab first and it's failed, there's no problem. I can go to surgery and sort it out then. It just extends the whole process for the poor owner, but it's not like you've missed the boat. You don't have to operate immediately. You can still get a great result for surgery down the line. So you can still take time, 8 weeks, whatever, try your rehab, see how you go, and then go to surgery if you have to.
So I love the fact that you say your clients or your patients have to earn their surgery, because it's, I mean, the perception for most people, I mean, if I just think about human surgeons, is they just want to cut, right?
Yeah.
So that's all a surgeon wants to do is cut. Yeah. And you often hear people when they go to somebody, they've got back pain, and they'll be like, just don't go to a surgeon. They're going to operate. That's all they're going to do. Yeah. So you're like the complete antithesis of that as a surgeon, which is awesome. I think, the fact that you have this sort of plan where you can delay the surgery potentially, I think is great for pet owners, because especially those ones that are on the fence, because sometimes, I think they feel this pressure. I have to operate now, and they don't know what to do. And at least we give them options, and then they really feel like they've tried everything, right? They've done everything right by their pets. They've tried the conservative approach. And now, why do you think it is that most other surgeons are rushing towards doing surgery? Do you think it's just a lack of education in the conservative approach? Because to be honest, I qualified now 21 years ago. And we didn't learn a lot at vet school about a conservative approach. I remember it was sort of like, if the owner can't afford the surgery, then you don't have to do it, kind of thing. And this is what you can try. But it was really a small part. It wasn't the main part.
Yeah. That's right. I mean, we were still part of the post-50s orthopedic, fix everything with orthopedic surgery if you can, which has changed now. The whole paradigm is changing, and the rehab field is growing exponentially. And it's been wonderful to be part of it. But I don't think they're passing that information on yet to the students around the world. I don't think there's a rehab subject which the vets are getting. I'm not sure. My son will tell me. It'll come in, I'm sure. It can't be ignored. But I'm not sure how much in the surgery department is taught about conservatives approaches and physio and rehab. But it'll come. It's a time. Everything evolves, and it can't be ignored. It's there and it's growing. So I think you touched on something there that's very important for me as well. Is I get these poor owners have driven, from all over KZN, even from Joburg. They've had this terrible pressure put on them that they must operate on this dog, and if they don't, they're bad owners. And it's not the case. They've got some time with cruciate injuries. It doesn't have to be fixed straight away with surgery. You got time to explore your options, and you'll get there in the end, one way or the other.
What do you think the worry is? To wait. I mean, are they worried that there's going to be arthritis setting in? Because we know that eventually that will, but that's not going to be in the short term, right?
No, and basically those dogs get arthritis no matter whether you operate or not. And in fact, it's quite interesting looking at these prolo cases I've done and getting them rehabbed and healed without opening the joint and having done no surgery at all. And I'm x-raying those knees as a just out of interest when they come in for something else 3 years down the line. And those knees are surprisingly free of degenerative joint disease. Not all of them. Still another whole lot of studies I've got to do to see, but it's the fact that there's even one that hasn't got any arthritis 3 years down the line from a complete cruciate rupture that was healed conservatively. The fact that I've even got one, and there's more than one, is amazing, and basically then explain or counteracts the fear that if you don't operate, your dog's going to be crippled with arthritis and never walk properly on that knee again. And when we do X-cap surgery, they get arthritis, they get degenerative joint disease, osteoarthritis in those knees, guaranteed. There's hardly any, there's none that won't have it, but it's visible on X-ray, but not clinical usually. So that big fear about, it's going to get terrible DJD, that it's valid in the bigger dogs maybe, but it's not enough of a fear to say you've got to go to surgery straight away.
Yeah.
You've got time
I mean, Steve, you've been a veterinary surgeon now for 33 years. Okay. Yeah. So is it correct to say is it more?
Yeah. So it's 35. I was 2 years in the army. Yeah, that's right.
Okay. So is it fair to say that at some stage you were the cut surgeon? Like, I just want to.
Oh, definitely. Oh, absolutely. 100%. So when I came out of varsity, I was the cut surgeon. So I would try and fix everything with surgery. So from 88, when I started at Westville Vet, right through till probably 2013, somewhere around there. If I could fix something with surgery, I would do it. And then my mindset started changing. And it comes with age. It comes with the thought of, I've done this radio before and it didn't work out well. I don't want to go down this path again if I don't have to. And I must admit, part of it was the ego thing as well, if I look back. So it was an ego of it wasn't even about, is it right for the dog? It was about, I want to see if I can sort this out surgically. I'm going to cut this lump away. I'm going to do this up because I've never done it up. And it was a bit of an ego drive. It's like, this is a challenge. this is surgery, I'm going to do it. And sometimes it was the wrong thing to do for the animal and for the owner. And then I'd look back and I'd explore it. And what were my motivations? What was my motivation there? Yeah. And it was more sometimes about me than about the patient and the owner. And that challenge and the self-satisfaction that I got this difficult op right, or it didn't work, but at least I tried, kind of thing. And so it's definitely changed from about 2013, and much more now about I've done so much surgery. I've lived through so many disasters. Your dog's got to earn its surgery. Yeah.
So what was the thing that caused that shift? I mean,
I think it's just age and experience and self-appraisal, examining your motives, examining why you do things, and just it's a lot of self-examination. Okay, well, why are you actually doing this? Is it the right thing to do? Yeah. Is it right for your pet, your patient? Is it right for the owner? Or is it just for you, kind of thing?
Yeah. All right, let's go back to that small versus large breed dog. So, like, if we look at the different sizes, do we generally find that the smaller breeds we're going to do a conservative approach, or more likely to do the conservative approach, and the larger breeds we're more likely going to operate?
Yeah, 100%. That's right. And there's, the factors there are the smaller, the less force on the knee, the more chance they're going to heal without needing surgery. The quadriceps are going to build enough strength, rehab enough strength, so that when they weight bear, this is an interesting thing I found, especially with doing a lot of prolap, is that you do not have to eliminate the cranial draw or the anterior thrust completely to get a sound dog. Because when we palpate the cranial draw or the anterior thrust, it's usually non-weight bearing, sedated. Okay, so the amount of looseness we're feeling in the knee there is absolutely not what's happening in the knee when the dog is weight bearing. When the dog is weight bearing and the muscles are contracting, the joint is more stable. So I've got lots of dogs now where I will palpate those knees at the third prolo. So we do prolo every month for 3, and there's still quite a draw, 3 or 4 millimeter draw, but they're weight bearing much better. And you can feel there's palpable fibrosis around that joint. So when they take weight and those quadriceps contract, the knee is more stable than it was before you started, and that's why they weight bear better.
Yeah.
And the other reason why little dogs often do better is because there's less chance of meniscal tears in little dogs. They do still get them, but they're far less common. So meniscal tears plague us in the big dogs, you really can't sort those out without surgery. Yeah. You can leave them. They eventually grind away. Some of them 6 months, 8 months, they come right. So some surgeons actually just leave them. But I've seen the dramatic difference between a very lame dog with a meniscal tear and already 3 days post-op, when you've sorted out the meniscal tear, they're so much happier and weight bearing so much better. And humans describe a meniscal tear as a very painful thing. It's like a knife moving in and out of your joint, and it catches you, and it's incredibly painful. So, if I'm pretty sure a dog's got a meniscal tear, then I am going to go to surgery, because I know I can make that better.
Yeah, so that's obviously one of the contraindications for doing the conservative approach. Are there any other factors that we would find that would prevent us from going down that conservative route?
There's very few that I can think of. You've got time. You don't have to rush into the surgery. Yeah, I actually really can't think of any contraindications to starting with a conservative option and keeping surgery on the table, but not starting with it.
Yeah, I must say, from a rehab perspective too, if there is a meniscal tear, it's really difficult to do our job because they're so painful. Yeah. And, our main goals are to manage their pain and to strengthen them. So to build those muscles, to offer some support for that knee. And the problem with that meniscal tear is because they're so painful, we're not able to manage the pain. And because we can't manage the pain, we can't strengthen.
Exactly.
So we just go backwards, Yeah. From a rehab perspective, we'll do a very similar, like I think you said, you do sort of 9 to 12 weeks or so of your conservative approach. And I would generally do the same thing. And I have 3 major goals. So I want to see an improvement in lameness. I want to see an improvement in muscle mass, or at least maintenance of muscle mass, so no losing of muscle mass. And I want to see an increase in the range of motion of that stifle, to see that there's extension. And normally when I have all 3 of those things, then I know that, the conservative approach is working, and then I'll continue. And if it isn't, if I don't have all three of those things, so I have to have all three, then I'll usually say, okay, we need to go for surgery. So you have a really interesting approach because you're using a combination of prolotherapy and rehab. Won't you run through your protocol of exactly how you treat these cases before they earn their surgery?
Sure. So yeah, once we've got the owner on board and we're going to try the conservative approach, I'll do the first I'll take a video of how the animal's walking, and I will do the first prolotherapy, and then we will start rehab the following week. I've got 2 rehabilitations that they just work full time. I just send them so many patients, and they're just rehabbing knees. And there's beyond doubt in my mind, if you combine the 2, your success rate is way better than if you just do the one or the other. Yeah. So they'll have weekly rehab, and then they'll come to me 4 weeks down the line. We'll touch base. We'll see how the dog's walking. We'll look at my first video. We'll look at the dog on the day. I'll palpate the knee, get an owner's impression of how things are going. Are they happy? How did they manage the prolo? Was the dog really sore? Do you want to carry on doing it? Do you feel it was too painful and you want to do something else? Are you still on board? Just touch base, make sure they're still on board or not. And then, most of them find the dog is sore for 2 days post prolo, and then they're fine and often better quite quickly. And there's very few that say, no, I don't want to do that anymore. And most have improved subtly. In 4 weeks, there's often not a dramatic improvement. But at 8 weeks, that's when you really start seeing the improvement. So I usually say to the owners, if they haven't seen much improvement after 4 weeks, it's too soon to give up. You got to do the second prolo and carry on with the weekly rehab and get to 8 weeks, and then look back. And often by then you've got a dramatic improvement, and the owners see the difference, and they're happy. And then we do a final one so it'll be 4 weeks. Prolo. So at 8 weeks is the third prolo, and then I normally don't see them anymore after that unless there's a problem. They carry on with rehab, but the rehab gets less and less, and they're in the hands of the rehabilitators then to make the call how often they want to see them going forward. And they're great, the ladies. They send me videos of how my patients are doing when they come for rehab, and we communicate on WhatsApp a lot, and how they're doing.
And every time you're doing the prolo, they're having to have general anesthetic or sedated?
No, we often do it while the owners wait. It takes about an hour and 15 minutes. They're sedated with Domitor and butorphanol, and then a bit of propofol added if they're still a little bit painful when we're injecting, and then we reverse, and they go home. So it's a quick procedure. It is painful. I do explain no pain, no gain. I'm going to hurt their dogs, and we give them Tramihexyl and Panado for 5 days, but the vast majority only need it for 2 days. They don't usually need it more than that.
And is this your standard approach now for all your cases? So
Pretty
none
much.
of them come in and get operated unless they've got a meniscal tear.
The two categories that come in and go straight to surgery are the ones where the owners are adamant they want surgery, and there's not many of those, but there are some. Yeah. And then the others where I'm worried about that knee. It's really puffy and marked diffusion, and there's a click in that joint, and I'm thinking, there's more going on here than just a straightforward cruciate tear. And I'm going to the owner, look, you can try prolo, but I have my doubts. Even those ones, the owners are still often say, no, I want you to try prolo first, Steve. We just can't face confining this dog for 6 weeks and all the possible, you show them pictures of TTAs and fractured tibias and fractured cages and all that. And you say, this is all that can happen. Ooh, okay, well, let's try the conservative first, So, yeah, I guess that's also, touching back on why do we not maybe rush into as much surgery as we used to. So I wouldn't dwell so much in the past on all the things that could go wrong with the owners when I did surgery. I would just say, no, we got to do it. And then I would deal with the problems afterwards if they happened. But now the way things have gone and owner education, you need to deal with the potential risks of any procedure you're going to do. And in telling them all those risks, often they back out of surgery, So I think that's also a reason why on my particular field is that I'm starting to do conservative before surgery, because I'm explaining better all about the potential complications that we could face post-surgery, and have to deal with.
So I remember from that episode 2, you had started to record some of your cases. So I went and I wrote down, after listening to that, some of the cases that you'd had. So at that time in 2017, you'd done 238 cases. You'd had one side effect, which was a septic arthritis, which you thought maybe was just you hadn't prepped correctly. And now you do a full sort of surgical prep. And then you treated 30 dogs in the contralateral limb. And after 1.5 years, not one of them had come back. And, we know from studies that 60% of cases after 15 months or so rupture the contralateral side. So that's something that is really, really interesting. So in all these cases that you're treating, are you always injecting both knees, or are you just doing the one?
Yeah, basically, I say to the owners, when you get your dog back, both knees are going to be shaved and clipped and have been injected. And the reason is not because I got confused and did the wrong knee first. It's because I've got a plan. Okay, and it seems to be working amazingly well. So by far the majority of our, especially the larger dogs, the dogs from 15 kilograms upwards, the type of cruciate rupture is not the acute overburden of a healthy white, shiny, healthy white cruciate ligament where the staphies jumped up 6 meters for a monkey, or the border collies leapt into the air for a frisbee. Those type of cruciate injuries happen, but they're actually not often. They're rare. They're 10%. The most common is some sort of synovitis that is starting in now, especially our large breed dogs from a year of age. They're starting to get this sort of synovitis, low-grade inflammation of the knee, which results in a weakening and a degeneration and a yellowing of these cruciate ligaments, and they start to stretch, and then they go. So nobody knows yet why, where, how. But an idea I had as well, if I'm treating the one that's gone, I know the other one's going. It's like almost guaranteed. Same disease, same dog, same 2 knees. Let me just, out of interest, inject those ones and maybe create some inflammation and some healing, periarticular fibrosis and stability, take a bit of pressure off the degenerating ligament. Maybe we'll prevent or delay that side going. So that was my rationale. It's untested anywhere in science. It was just a plan I had myself, and I just wanted, and I got the owners on board, explained it, and all of them were happy. It doesn't seem to deleteriously, how do you say that word? Yeah, deleteriously affect the animal in any way. So that was 30 dogs. That I did send the stats to you. I recently looked them up, but I just want to recall because I think I WhatsApped it to you, so I'm just going to look it up. Okay, so yeah. So now it's 210 palpably normal contralateral stifles treated with 1, 2, or 3 prophylactic prolotherapy since 2015. So far, 28 have returned to me with a cruciate rupture. So that's 13%. Yeah. Compared to 54% in the stats. So it's not perfect stats because I don't know where they might have gone elsewhere with the cruciate rupture. The dog may have been put down, or anyway, but the bottom line is it looks like it's doing something to help prevent, delay, or prevent the other side from going. So that is enough information for me to carry on doing what I'm doing and treat the normal knee as well, the so-called normal knee as well.
Yeah.
Yeah.
Out of those cases so like looking at the small versus the large breed, when they come now and you go for your 12 weeks of prolo and rehab, what percentage do you know offhand of the small dogs go ahead for surgery, and what percentage of the large breeds go ahead for surgery?
So I quickly looked at the stats just for small dogs, just under 15 kilos. All the prolos I've done on small dogs, it's 87 little dogs, mostly Yorkshire Terriers, Maltese, Jack Russells. Only one ended in surgery with me. They may have gone elsewhere. And funnily enough, that surgery failed anyway. We never really got that knee right. So it's incredible stats for little dogs in my hands. Yeah. 87 little dogs, only one ended in surgery. Yeah. The rest all rehab brilliantly. And these little guys I see coming back for other things. And these are the dogs, you palpate that knee, and honestly, you would never know that some of them either had a cruciate rupture. There's no instability. There's no DJD. It's incredible. Yeah.
I mean, and
the bigger dogs, I haven't got those exact stats, but it's roughly 10%. So the owner survey I did last year came back very similar to my ex-cap surgeries. This is across all sizes. The 65% full return to function, 25% much better, but not perfect. But owners happy for them to live like that. These are not working dogs. They're pets. They can deal with the fact that if he goes for a run on the beach. The next day he's going to limp a bit. He has rheumatoid for a day or two, and then he's fine again. And then 10 to 15% failed, needed surgery. And those are the meniscal tears.
Yeah. And so you say those are the very similar stats that you have when you do the extracapsular surgery?
In my hands, there's hardly any difference between prolo and ex-cap surgery. So I hardly ever do ex-cap surgery anymore.
Yeah. Really, really interesting. We're looking forward to a Facebook Live that you're going to be doing. When we're going to chat more about prolotherapy. I find it so interesting, and it's amazing as a veterinary surgeon, the change in your mindset about it. And I just want to thank you for supporting rehab as well, because I hear that you have your 2 vet rehabbers that you refer to. I wanted to say those cases of those 87 small ones, I mean, because you're also sending them to rehab.
Yes.
I think if that had gone to surgery elsewhere, the rehab therapist probably would know and would tell you, hey, that one went to surgery. So
I would hope so.
Heard, I think that there's a good chance that those are great success.
Yeah.
Well done, Stephen. Thank you so much for recording all of this. It's been amazing for me to watch your journey from 2017 now, and all the cases that you treated. I love the fact that you're also so open to educating, so doing webinars, and I know that you have changed the minds of many vets in South Africa. So you've got quite a lot of vets on board, right?
I have. It's been very rewarding. I've had some negativity, but overall it's been an amazingly wonderful feedback. I've had emails and messages back from vets saying, Steve, you've changed my life. I'm in a little town in the middle of Africa somewhere. I don't like surgery, but I can do something now for these knees that I never used to be able to. And sometimes it works, even if it only works 10 out of 100, it's better than nothing. And they're just so chuffed, So that's been very rewarding too. And they say, I can give owners another option, because that's you got to do surgery, otherwise I can do nothing, amputate or let it limp forever, Now they've got another option to give the owner, which is very doable, easy to do, and almost nothing to lose. Side effects are so minimal, the risk is so little.
And also quite a lot more affordable for the clients.
Absolutely, so much more affordable. Because that is a huge thing now, is obviously the expense of surgery, especially the big TPLOs, and that it's quite a big outlay. Fortunately, we've got lots of more pets on pet insurance schemes, so we do still get to do those big surgeries because of the pet insurance schemes. But many people, just surgeries out of the question just from a financial point of view.
So I wanted to ask you, do you miss cutting? Because you've sort of as a surgeon now created a system in where you don't get to do the surgery that
I don't miss cutting. I still do quite a lot of cutting. So I still do, lots of spinals and back and fracture repairs and TTAs. I really enjoy doing TTAs, TTA rapids. It's a nice op. I can, without tempting fate, I can give the owners a 95% success rate. So I've kind of got it right in my hands. I'm confident with the technique. So I still enjoy cutting. I like going to theatre, putting my music on, having a break from all the people and the phone calls, and then it's just me and the patient and the nurse watching the anesthetic. So I still enjoy that. But I'm happy. I'm really happy that I don't have to cut on every patient.
Yeah. Awesome, Steve. It's been fabulous chatting to you. Thank you so much for your time.
Absolute pleasure. Thanks,
Have an awesome day. Bye.
Okay, cheers.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. And please, if you get a moment, head over to Stitcher or iTunes and leave me a review. It's a really lonely job being a podcaster, and so the only time I get to hear from you or know that you're out there is when I get a review. And know that I read every single one of your reviews. So to those of you that have left reviews, I want to say a very, very big thank you. Every time we get a review, it really helps to get the Veterinary Rehabilitation Podcast out there to all the vet rehabbers all over the world. All right, vet rehabbers, so if you are looking for more continuing education in the field of veterinary rehabilitation, head over to onlinepethouth.com. Go be awesome, guys.